Now we will be discussing acute GI bleeding. I'm Dr. Linda Lee, and I have nothing to disclose. We will talk about resuscitation, as that is truly the most critical thing when you first encounter somebody with GI bleeding, and then discuss about how we might be able to differentiate between whether it might be an upper versus a lower GI source. And finally, I will also discuss management of both upper and lower GI bleeding. First, we'll start off with some definitions. Upper GI bleed is defined as any bleeding that occurs proximal to the ligament of Treitz. Then from the ligament of Treitz all the way through the ileocecal valve is small bowel bleeding, as nowadays we do have instruments and equipment that will allow us to intervene upon this bleeding as well. And then finally, lower GI bleed is defined as any bleeding occurring from the ileocecal valve, the cecum, all the way through down into the rectum anus region. Occult GI bleed is bleeding that you cannot see with the naked eye, but can be found on, for example, a stool card exam, as seen here, where it turns blue, versus overt GI bleed, which simply refers to GI bleed that can be visualized by the naked eye. Obscure GI bleeding can be either overt or occult, and the key thing in this definition is that there is no source that has been defined for the GI bleed despite the patient having undergone EGD and colonoscopy. And finally, acute GI bleed has been going on for less than 3 days, while chronic GI bleed is slow and or intermittent blood loss, which can be, for example, in somebody who's having occult GI bleeding and develops iron deficiency anemia, or having small amounts of intermittent bright red blood per rectum. So now we'll move on to epidemiology. And on this slide, blue represents upper GI bleed, while red represents lower GI bleed. And as you can see here, upper GI bleed accounts for about twice as many hospitalizations per year in US adults than lower GI bleed. Also, upper GI bleed, again shown here in blue, accounts for about twice as many of all GI bleeds. It accounts for about 40% of all GI bleeds, while lower GI bleed accounts for a little bit over 20% of all GI bleeds. Now, about 80% of all GI bleeds stop spontaneously. And moving on to mortality, the overall mortality thankfully is quite low for both upper and lower GI bleed. The thing to note here is that the mortality rate in somebody who is an outpatient and presents to the hospital with GI bleed, the mortality rate in those patients is quite low. However, if the patient is already hospitalized and then starts having GI bleed while an inpatient, their mortality rate is far greater, over 20%. So these are the patients that you certainly need to be worried about and pay more attention to. Now, as with everything, it's very important to do a thorough, targeted history and physical examination in anybody who presents with GI bleeding. Some of the key questions that you want to ask are, have they ever had a history of previous GI bleeding? And if so, what happened? Where was it? Did they need transfusions, etc.? You also want to assess their comorbidities, as this impacts on the risk of GI bleeding as well as the safety for performing sedation and procedures in those patients. And for example, those patients at risk for hypoxemia would be those who have a history of cardiopulmonary disease. Those at potential risk for volume overload include patients with cardiac or renal disease. Those at risk for ongoing bleeding, of course, include those patients who have coagulopathy or thrombocytopenia. And also those at risk for potential aspiration is important to assess, such as in those patients with dementia or encephalopathy, as they may not be able to adequately protect their airways and might need to be intubated. Of course, medications is important. You want to ask them specifically about if they have been taking any aspirin, NSAIDs, antiplatelet agents, anticoagulants, SSRIs, iron and bismuth are important to ask about because both of those will turn the stool black. And of course, if they drink any alcohol. Regarding symptoms, you want to pay attention to specific symptoms, such as if they have any dysphagia, odynophagia, history of vomiting, abdominal pain, as well as what their stool color looked like if they were able to look at it. And also assess for any hemodynamic symptoms, such as dizziness, palpitations, chest pain, and dyspnea. On exam, you want to be sure and note their heart rate, blood pressure, as well as orthostatics. If they have passed stool or blood, you definitely want to look at that. And if not, you do want to perform a rectal exam, as well as a thorough abdominal exam to assess for any tenderness. Labs that are important, of course, include CBC, as well as BUN, creatinine, LFTs, PT, and PTT. You certainly want to send off a type-in screen immediately and perform cardiac enzymes if there is any concern for a cardiac event in that patient. So now that you've done a thorough and targeted history and physical exam, it's important to resuscitate them adequately before anything gets done. So the two questions are, is the patient stable? And then the next issue is, do we need to correct any coagulopathies? So in terms of whether or not the patient is stable, if somebody is orthostatic, this implies at least a 15% loss of blood volume, while if the patient is having supine hypotension, this implies at least a 40% loss of blood volume. All patients who are having GI bleeding should have at least 2 large bore 12 to 18 gauge IVs. If that's not possible, a cordis is preferred to a central line because it is a larger gauge. Therefore, you can more rapidly infuse IV fluids as well as blood products. And before blood products are available, you do want to start volume resuscitating the patient with IV fluids. And once PAG red cells are available, the goal hemoglobin for transfusion is 7 grams per deciliter or greater. However, this goes up to 9 grams per deciliter or greater if the patient is at increased risk for adverse events from having severe anemia, such as severe cardiac patients. Now, the goal hemoglobin in somebody who is having variceal bleeding is different. You do not want to over-transfuse these patients, and we'll discuss that in a little bit. But the goal hemoglobin for these patients is around 8 grams per deciliter. And finally, you do again want to assess if the patients might need to be intubated in order to protect their airway. And these patients include those who are having ongoing hematemesis or have a change in their mental status and just cannot protect their own airway. So now that you've started resuscitating the patient, the next issue is to address any coagulopathies they might have. And the goal INR is less than 1.5 with platelets greater than 50,000 in somebody who's having active GI bleeding. However, you do not need a normal INR before we can perform procedures, endoscopy, colonoscopy on these patients. The goal INR is less than 3 before we can safely proceed with EGD and or colonoscopy. You do want to hold in the very short term aspirin, NSAIDs, antiplatelet agents, and anticoagulants. It's debatable whether or not SSRIs should be held. And if the INR is abnormal, you do want to correct that either with FFP, vitamin K, or Kcentra. Now, this graphic to the right just shows you the risk of GI bleeding, upper GI bleeding versus lower GI bleeding with various agents that could cause GI bleed, as well as the protective effects of PPIs versus H2 blockers. And as you might expect, the use of NSAIDs, aspirin, anticoagulants, and non-aspirin antiplatelet agents certainly increases the risk of upper GI bleed, most severely with anticoagulants. However, they all also increase the risk of lower GI bleed, including NSAID use. So that's certainly important to remember that NSAIDs can be a cause of lower GI bleed as well. Now, if the INR needs to be corrected, again to a goal less than 1.5 in the acute active bleeding phase, FFP is certainly very good at rapid reversal. However, it's important to remember that the reversal is short-lived, only lasts about 3 to 5 hours. And also, if the patients need a lot of packed RBCs, for every 4 units they're transfused red blood cells, they should be transfused a bag of FFP. Things to remember, though, are that, as I already mentioned, the effects of FFP are short-lived, but also the volume of FFP needed to reach a target INR is rather high. So for example, when you look at this table, if the patient's initial INR is 6 and your goal is to get them to 1.5, you need to transfuse them 3.5 liters of FFP to get there. And at the bottom, if they come in with an INR of 2 and you're just trying to get them down to 1.5, you still need to give them about 1.5 liters of FFP. So it is certainly a large volume of fluid that could cause some issues in your cardiac or renal patients. And so this leads us to the 4-factor prothrombin complex concentrate, which is a combination of factors 10, 9, 7, 2, protein CNS. The attractive things about this is that it acts in less than 30 minutes to bring the INR down to less than 1.3 and requires about 85% less volume than FFP. Of course, the downside is that it's about 6 times more expensive than FFP. However, this is something important to remember and use in the appropriate patient population. There's also vitamin K, which comes as IV, oral, or sub-Q. IV is the preferred route in somebody who is having major GI bleed. Very rarely anaphylaxis can happen. It's unclear if this is dose-related, and the patients should be monitored when they're receiving IV vitamin K. The exact dose to administer is unclear. Usually 5 milligram dose is given at first. The thing to remember with vitamin K is that the effects are permanent, but it also takes longer for the full effect to occur, anywhere from about 12 to 24 hours following administration, although it is a little bit faster with the IV route. So now that you have adequately resuscitated the patients and corrected their coagulopathy issues, you also want to address and assess the severity of their GI bleed. You want to try to identify those high-risk patients so you can triage their care more appropriately to whether they need to be in the ICU versus a floor bed. And you also want to try to identify the low-risk patients who may potentially be able to be discharged early. There are multiple validated scoring systems designed to try to predict the risk of rebleeding, need for surgical intervention, and mortality rate. In particular, with upper GI bleed, there are far fewer studies available in lower GI bleed. And this slide summarizes most of those predictors of mortality from the various studies. Age over 60, a patient with comorbidities, systolic blood pressure less than 100 or heart rate over 100, stool that appears as bright red blood per rectum or melena, hemoglobin less than 10. If the patient is an inpatient when they begin GI bleeding, as we've already discussed before, and if the etiology is intestinal ischemia, those are all predictors of increased mortality. On the right, you see here endoscopic stigmata and variceal bleeding. And we'll talk about endoscopic stigmata in a little bit, but depending on what's seen on EGD, that also predicts rebleeding rate, etc. So here, in terms of triaging upon admission, if the patient is unstable, they should really be in the ICU and carefully monitored. Now here in the middle, if they are unstable and or have change of their mental status, or they're just continually having hematemesis, those are the patients where it's important to protect their airways and intubate them. And so that's very important not to forget. And otherwise, in the patients who are stable, mentating properly, not having ongoing hematemesis, they can be admitted to a monitored hospital bed. Now, moving on to trying to differentiate if the patient might be having an upper GI versus a lower GI bleed, it's important to remember that about 10 to 20% of patients who initially present as what is thought to be lower GI bleeding ultimately are proven to have an upper GI source. Now, some clues to whether the patient could be having upper GI bleeding include hematochezia with hemodynamic instability, which implies that there is bleeding happening so rapidly from above that is passing very rapidly through the GI tract, not having time to turn into melena, and the patient is hemodynamically unstable. Another clue to upper GI bleed, of course, includes melena, whether by history or on your rectal exam, if the patient has had a history of upper GI bleed before. And of course, it's important to pay attention to the BUN, because if that is elevated in somebody, that can imply an upper GI source. And in fact, if the ratio between BUN to creatinine is greater than 30, this implies that the patient has an upper GI bleed. If the patient has clots in their stool, this implies a lower GI source. Now, a question that comes up fairly frequently is, should we drop an NG tube to look and see if this might be an upper GI source rather than a lower GI source? So should we be doing that? Patients hate it, but is it actually helpful? Well, when you look at this, you see that the sensitivity of the NG tube aspirate in being able to predict if somebody's having upper GI bleed ranges widely from 42 to 84%, and it's only 55% specific. More recent study looked at patients who had an NG tube placed versus those who had not had an NG tube placed, and found that there was actually no difference in mortality rates, need for transfusion, surgery, or length of hospital stay. So at this point, we don't routinely recommend dropping an NG tube for the purpose of trying to determine if the patient might be having an upper GI bleed. Now, what about gastro-occult cards? Are those helpful? Well, if they are positive, they are not helpful at all. As you can see here, the specificity is only 18%. So what this means is that if the gastro-occult card is positive, this is overwhelmingly likely a false positive. However, if it is negative, it is highly sensitive, 96% sensitivity. So if the patient has a negative gastro-occult card, this is very reassuring that it's actually not an upper GI bleed. But if it's positive, you should just ignore it. And we don't recommend doing the gastro-occult card at all. So moving on to management for upper GI bleed in non-variceal bleeding. This is the range of differential diagnoses that you can encounter. Most commonly, of course, we encounter peptic ulcer disease followed by Mallory-Weiss tear, which classically presents in people who have been vomiting and then they start having some hematemesis, erosive gastritis, duodenitis, or esophagitis, and less commonly AVMs, duodefoid lesions, neoplasms, GAVE or gastric antral vascular ectasia, and Cameron ulcer. So there are some important things that should be done even before a gastroenterologist does an EGD. And this, of course, is starting all patients with suspected upper GI bleeding on an IV PPI. And this has been shown to reduce rebleeding rates, and we typically recommend using an 80 milligram bolus followed by an 8 milligram per hour infusion. Some people suggest using BID dosing of the IV. The other important thing to remember is that erythromycin IV may be very helpful in clearing the stomach of blood clots before we go down to look in there, because all too commonly we'll go down and not be able to see very well because of the presence of abundant amounts of blood clots. So giving the patient IV erythromycin, 3 milligram per kilogram, about 30 to 90 minutes before the EGD has been shown to help with visualization. And then, of course, comes the upper endoscopy, where we go down the patient's mouth and evaluate their esophagus, stomach, and the proximal duodenum. And these are some of the things that we might encounter when we're doing the upper endoscopy. So you see here on the upper left here, this is a classic example of what we call a clean-based ulcer in the stomach. It's white, smooth, no dark marks or no protuberances in it. This, as well as if they actually do have a pigmented but a flat spot within it, both of these have a very low risk of rebleeding, certainly less than 10% risk of rebleeding in these patients. Compare that to these bottom three pictures, which have a much higher risk of rebleeding associated with them. This one shows a picture of an adherent clot, and that rebleeding risk varies anywhere from 8 to 35%. This picture shows a non-bleeding visible vessel, which is a little protuberance in the middle of the ulcer, and that's associated with about a 50% risk of bleeding. I'm sorry, can I just redo this slide? So now these represent the possible findings that you could see when you do the EGD. You could see a clean-based ulcer that is defined as, again, being clean with no protuberances, nodules, or pigmentation within it. This shows a pigmented flat spot within the ulcer, and both of these are associated with very low risk of rebleeding, certainly less than 10% risk. Contrast that to these three pictures at the bottom that are all associated with a much higher risk of rebleeding, starting with an adherent clot that is stuck on the ulcer. Because you don't know what's underneath it, it could be a clean-based ulcer underneath it. However, it could also be a non-bleeding visible vessel underneath it, which is associated with a much higher risk of rebleeding. Hence, the risk of rebleeding varies anywhere from 88 to 35%. The non-bleeding visible vessel is defined as a protuberance within the ulcer and is associated with about a 50% risk of rebleeding. And of course, if somebody is found to be actively bleeding, they have a near 100% chance of rebleeding. And it's important for the endoscopist to accurately characterize these different findings, because if the patient is at low risk for rebleeding because they only have a clean-based ulcer or a pigmented flat spot within the ulcer, these patients do not need any type of endoscopic treatment during the upper endoscopy. However, if the patient is found to have an adherent clot, a non-bleeding visible vessel, or certainly if they're having active bleeding in front of your eyes, all three of these categories of patients have a much higher risk of rebleeding, and therefore endoscopic treatment should be rendered in these patients. And what do we have to offer? There's a variety of tools that we have that we can use, starting with an example of an injection needle down in the lower left here that we can use to inject various materials, including epinephrine and saline. We can also place metal clips on non-bleeding visible vessels or bleeding vessels to try to stop them. There are various forms of cautery. In the middle, two panels here showing On the top, argon plasma coagulation, a non-contact form of cautery, and on the bottom, a BiCAP probe that is a contact form of thermal therapy. And then this, of course, are bands loaded onto the tip of a gastroscope in order to perform banding, typically in variceal bleeding. And this is a radiofrequency ablation catheter that can be used oftentimes in situations such as somebody who has gastric antral vascular ectasias. Now, after we've done the EGD, what should we do for them? Well, in somebody, again, this really depends on their risk of rebleeding. So in somebody who either has a clean-based ulcer or just a pigmented flat spot, again, those patients are at very low risk for rebleeding, so you can just feed them a normal diet and discharge them on a PPI once a day with appropriate follow-up per GI. All these patients should have H. pylori checked, and it could be serology, or stool antigen if biopsies were not done during the upper endoscopy. However, in the bottom three panels again, these patients with an adherent clot, a non-bleeding visible vessel, or active bleeding who are at much higher risk of rebleeding, these patients should be watched for the ensuing 72 hours and left on an IV PPI BID for those 72 hours, and their diet can be slowly advanced. So moving to upper GI bleed that's variceal in origin, early management is very important because in the first 14 days, this is the most important time period because most inpatient deaths are due to rebleeding in this patient population. Fortunately, mortality rates have dropped between the period of 1980 to 2000 with variceal upper GI bleeding. And in this patient population, resuscitation is a little bit different, as I alluded to earlier. You should definitely consider intubating these patients. I would have a very low threshold to intubate these patients to protect their airway when we're doing the upper endoscopy because blood can reflux back up from the esophageal varices and they could aspirate that, which would be a bad situation. And it's also important not to over-transfuse these patients because that could exacerbate the variceal bleeding by plumping up the varices. So the goal hemoglobin is about 8, and EGD should be performed within 12 hours in all these patients. And this just shows a classic example of a large esophageal varices here. There's a long column here as well as several to the right and even up at the top as well. Now, similar to non-variceal upper GI bleed, there's definitely important steps to take early on, even before we do the EGD. And that comes in the form of medical therapy with octreotide and antibiotics. Octreotide has been shown to decrease rebleeding in patients with variceal bleeding, although not mortality. And the dose given should be a 50 to 100 microgram IV bolus followed by a 50 microgram per hour drip for 3 to 5 days. Antibiotics is very important because multiple studies have shown that the use of antibiotics in these cirrhotic patients who are having upper GI bleed decreases mortality as well as infection rates. The antibiotics that should be administered would be either a quinolone in IV or oral form or ceftriaxone 1 gram IV Q-day for 7 days. Now, in somebody who's really in distress and having ongoing hematemesis and or you can't perform the EGD for some reason because perhaps they're too unstable, you can certainly perform balloon tamponade at the bedside, and this just shows the gastric portion of the balloon that's inflated, followed by the esophageal portion, to literally tamponade the varices so they would hopefully stop bleeding. It's important to remember that this is just a temporary bridge. It should be left in for less than 24 hours. and there should be some definitive therapy that is performed, whether it be EGD, TIPS, or surgery. And the initial success rate with the balloon tamponade varies widely depending on what studies you look at, anywhere from 30 to 90%. And of course, really the definitive management is EGD with variceal ligation, as you see here. These are literally rubber bands that we place at the base of these varices to strangulate them. In the older days, we used to perform endoscopic sclerotherapy, where we use a needle into the varix and inject sclerosins to them. We very, very rarely perform this nowadays. So to summarize, the early management of upper GI bleed before EGD in somebody who's having non-variceal upper GI bleed, the goal hemoglobin should be at least 7 or 9 in somebody who you're worried could have some events from having severe anemia. The goal INR should be less than 1.5, although it only needs to be less than 3 before we will proceed with an EGD or colonoscopy. Platelets should be above 50,000. IV PPI infusion should be begun, or potentially BID. Consider IV erythromycin to help clear the stomach, and hold all aspirin, NSAIDs, blood thinning agents if possible. And certainly if they are on anticoagulants and antiplatelet agents, you should confer with the appropriate consulting teams, whether it be cardiology or neurology, to have them on board. For variceal upper GI bleeding, again, it's important not to overtransfuse these patients, and the goal hemoglobin is about 8, because you don't want to plump out those esophageal varices and make them bleed even more. Have a very low threshold to intubate these patients to protect their airway, and also begin right away IV fluoroquinolone or ceftriaxone for 7 days, as well as an IV octreotide drip that is 50 microgram bolus followed by 50 microgram per hour for 3 to 5 days. Now we're going to switch gears and talk about lower GI bleed. So again, there's a whole range of differential diagnosis for lower GI bleed. Most commonly, we believe it's due to diverticular bleed. We also encounter it in neoplasia, ischemic colitis, angiodysplasia, as well as hemorrhoids, and of course post-polypectomy bleeding. And down at the bottom, you see here that upper GI source again can account for anywhere from 11 to 15 and even 20% of initially suspected lower GI bleed, and also unknown in about 12% of patients. Now, diverticular bleed. This shows you an example of a diverticulum with what appears to be a non-bleeding visible vessel, which again, if you extrapolate from the upper GI bleeding literature, would be associated with about a 50% risk of rebleeding, so therefore you would want to treat it. And on the right panel, you see that we've treated it by placing a couple of clips on it. Now, this shows you an example of ischemic colitis, which is actually non-specific findings. Other entities can have this appearance, but this particular patient had ischemic colitis. And this on the left panel shows you superficial ulceration in this area, with normal appearing colonic mucosa down below here. The right panel shows diffusely abnormal looking mucosa with no normal colonic tissue at all, and the diagnosis was made by doing biopsies. And ischemic colitis occurs because there's been a temporary decrease in blood flow to a portion of the colon. And classically, this occurs in the so-called watershed areas, which include the splenic flexure, as well as the rectosigmoid region. Now, this is an example of an angiodysplasia, which classically has this wispy, feathery appearance with a central feeding vessel in the middle. Now, in terms of what we can do in lower GI bleed, unlike upper GI bleed, there's multiple different modalities available to perform both diagnosis as well as render therapy. Colonoscopy, of course, would still be the gold standard, both in terms of diagnosis, where the diagnostic yield is about 45 to 100%, depending on what studies you look at, and also in terms of rendering therapy, which we're able to do about 10 to 40% of the time, and is accompanied by a very low risk of complications, less than 2%. At the bottom, angiography can also be used to render diagnosis anywhere from 35 to 86% of the time, as well as therapy. However, note that the complication rate is significantly higher with angiography at about 17%. Tagged red blood cell scan as well as CT angiography are both available to provide diagnosis only in these patients. So in lower GI bleed, unlike in upper GI bleed, there's a range of possible tests that one can do. Certainly consider doing EGD if you're worried it could be an upper GI source masquerading as lower GI bleed. And of course, colonoscopy is the test of choice. However, if that is negative or can't be performed, then the angiography can be done, as well as surgery as a last resort. And of course, you have tagged RBC scan and multi-detector row CT or CT angiography available as diagnostic modalities as well. FLEX-SIG can occasionally be considered in some patients. For example, if somebody had a large polyp removed from their rectum or sigmoid and they present with hematochezia, it would be very reasonable just to perform a FLEX-SIG rather than a full colonoscopy in such a patient. So this multidisciplinary approach is guided by the patient. If they appear to be having lower GI bleed but are stable, the test of choice should be a colonoscopy. If they're truly stable with a stable hematocrit and they're reliable, they can even be discharged and brought back within the week to have an outpatient colonoscopy done. However, most patients would be admitted for an inpatient colonoscopy. Now, on the other hand, if the patient is having ongoing lower GI bleed and is unstable, they're just pouring out blood from below, they should really go straight away to angiography. And if that's negative, then we can certainly perform a colonoscopy. And of course, worst case scenario will be needing to have surgical intervention. Now, for those patients who are having so-called moderate lower GI bleed, where they are continuing to bleed intermittently but they are stable, you have a whole host of possibilities here where if they're not prepped yet for us to perform a colonoscopy, they can certainly undergo a tagged RBC scan, or if they have normal renal function, certainly a CT angiogram. If that's positive, they can then undergo targeted angiography. If it's negative, certainly the patient should continue to be prepped for a colonoscopy. And if the colonoscopy is negative, again, you can certainly go back and revisit your diagnostic radiology options. So again, certainly colonoscopy in lower GI bleed is safe, less than 2% risk of complication. Perforation and congestive heart failure have been reported. The preparation techniques include a lot of go lightly, anywhere from 4 to 8 liters. If the patient cannot tolerate this orally, you can place an NG tube, and also consider giving them IV Reglan to help with any nausea. The issue of urgent colonoscopy that's performed within 12 to 24 hours of presentation remains a bit unclear, but it definitely does seem to increase diagnostic yield, although has not been proven to decrease rebleeding rates, length of hospital stay, or mortality. And to the right here, you just see here a few examples of what we could find during a colonoscopy. Up at the top, there's just blood with one diverticulum that you see here, but no true active bleeding. This just shows a diffuse erythema, diffusely abnormal mucosa, as well as down at the bottom here. So tagged RBC scan is very sensitive. It detects bleeding that occurs as low as a 0.1 cc per minute rate. And the way it's performed is that it's protectinate labeled RBCs, the patient's own RBCs that get labeled and transfused back to them. This lasts in their bloodstream for 24 hours. So if the initial test is negative, but they rebleed within that 24-hour period, the patient could be sent back down for another scan. The sensitivity ranges anywhere from 78 to 97%. Similar range of specificity, and accuracy of localization varies widely from 24 to 91%. To the left here, you see early image of a tagged RBC that's negative, and then later on, you see this blush here in the right lower quadrant, implying a potential right-sided colonic bleed, although this could also be a distal small bowel bleed as well. Now, multi-detector row CT or CT angiography is a little bit less sensitive. It requires a bleeding rate of at least 0.3 to 0.5 cc per minute to be detected. And this image just shows how it works. The patients are not given any oral contrast. They are only given IV contrast and then imaged. And this shows you the patient who got the IV contrast, and suddenly you see that contrast within the GI lumen. And a little while later, there's even more contrast in the lumen. So it implies that the GI bleeding is occurring right here. So the sensitivity for detecting the source of bleeding is very high in somebody who's having active bleeding, around 90%. But in patients with obscure GI bleeding, the sensitivity is not even 50%. It is highly specific, 92 to 95% specific, and has been shown to increase the diagnostic yield of colonoscopy by about 15%. It is likely more accurate for detecting and localizing the site of GI bleed than tagged RBC scan. Now, angiography, again, is the technique that the radiologist can use to both render diagnosis and potentially therapy. They use super selective microcatheters to get to the peripheral vessels. And you see here on this angiogram a blush of contrast out peripherally. A microcoil has been placed, and following that, there's no more leakage of contrast. This, however, requires a higher rate of bleeding to be detected, at least 1 cc of bleeding per minute, which is why most radiologists prefer that the bleeding be confirmed with either a tagged RBC scan or CT angiogram before proceeding to angiography. Ideally, this will be performed within 1 hour of a positive tagged RBC scan or CT angiogram. The times when it may be reasonable to proceed straight away to angiography without a preceding diagnostic scan would be, again, as we discussed earlier, in somebody who is hemodynamically unstable or having severe bleeding, because certainly these patients are likely bleeding at a much faster rate than 1 cc per minute. It is about 60% sensitive and 100% specific, but again, associated with a fairly high rate of major complications, which includes surgery, need for surgery, usually from ischemia or death. So to summarize, the pros of moving forward with radiology examination is that the patients do not need to take a preparation, and you can evaluate the entire GI tract. The cons are that both the tagged RBC scan and CT angiography are only diagnostic, and there is, of course, radiation exposure associated with these tests. And there are renal issues with IV contrast, and certainly a person who has renal insufficiency cannot undergo CT angiography. There's also potential for major complications associated with angiography, and also the potential for a time lag between radiology exams. Now, in terms of when to do surgery, about 18 to 25% of patients will ultimately need surgery to deal with their lower GI bleeding. A blind subtotal colectomy leads to the lowest rate of rebleeding at less than 4% and is associated with about a 2 to 6% mortality rate. Targeted segmental colectomy is associated with also fairly low rebleeding rates of 4 to 14%. and 0 to 22% mortality rate. Blind segmental colectomy is not recommended, as this is associated with very high rates of rebleeding as well as mortality. So to summarize the approach in lower GI bleed, in somebody who is having low risk lower GI bleeding and very stable, they should be prepared for colonoscopy. And again, one could consider an outpatient exam, but only in very select patients whose hematocrits have not dropped and who are completely reliable to return within a week to have their outpatient colonoscopy. On the other hand, somebody who's having severe lower GI bleed and hemodynamically unstable, you should certainly try to exclude an upper GI source. Consider sending them straight away to angiography and get surgery on board early. For somebody who's having ongoing lower GI bleed, who is stable but not prepped yet, certainly start doing a colonoscopy preparation. Again, consider whether this could be an upper GI source and should they have an EGD. And again, if they're not prepared, it's certainly reasonable to move forward with a diagnostic radiology exam, whether it's a tagged RBC scan or CT angiogram. So to conclude, in all GI bleed, it is critical to resuscitate them adequately from the beginning and they need at least 2 large bore IVs, transfuse the patients to an appropriate goal hemoglobin, correct any coagulopathies with FFP, vitamin K, or Kcentra, consider whether it's an upper GI versus a lower GI source. In somebody that you believe is having a non-variceal upper GI bleed, start them right away on an IV PPI drip or BID before the EGD gets performed, and EGD should ideally be performed within about 24 hours. For patients having variceal upper GI bleed, it's vitally important to start them immediately on IV antibiotics as well as octreotide. Before the EGD, consider intubating them, have a very low threshold for this, do an EGD within 12 hours. Now for lower GI bleed, again, this tends to lend itself more to a multidisciplinary approach that is tailored to the patient and how stable they are. A colonoscopy should be performed ideally within 12 to 24 hours. However, consider an angiography for those patients who are having severe unstable bleeding. And a tagged RBC scan or CT angiography is certainly reasonable diagnostic evaluation in patients who have less severe but ongoing bleeding and who are not prepared yet to have a colonoscopy. So question number 1. A 77-year-old male with a history of MI and atrial fibrillation on aspirin, clopidogrel, and Coumadin, and chronic renal insufficiency presents with bright red blood per rectum. He has had about 5 bloody bowel movements, feels lightheaded, and denies any abdominal pain, nausea, or vomiting. He has no history of GI bleeding and has never had a colonoscopy. On exam, his heart rate is 102, blood pressure 105/72, rectal reveals bright red blood on the glove with no stool. Initial hematocrit is 29, platelet 220, INR 6. The medicine house staff are holding aspirin, clopidogrel, and Coumadin, ordered type and cross, and 2 units of FFP to be given stat. The patient continues to pass bright red and maroon blood, remains tachycardic, but is otherwise stable. What do you suggest? A, colonoscopy now. B, colonoscopy in the AM after patient drinks more PrEP. C, tagged RBC scan. D, angiography. And the correct answer here is C, tagged RBC scan. Most likely, the patient is having lower GI bleed, although upper GI bleed is possible given his aspirin use. Colonoscopy now is not feasible as the patient is not prepared and has an INR of 6, which should be less than 3 before doing a procedure. While the patient can start drinking preparation for anticipated colonoscopy in 12 to 24 hours, he is continuing to pass bloody bowel movements now. This implies ongoing active bleeding that is likely at a pace rapid enough to be detected by tagged RBC scan. Therefore, he should undergo this study before angiography to help localize the bleeding source, especially given his chronic renal insufficiency. Question 2. 45-year-old male with a past medical history of hypertension, coronary artery disease, status post cardiac catheterization with stent placement on aspirin and clopidogrel presents with melena. EGD reveals the following. What medical therapy should occur after EGD treatment of this lesion? A, nothing. B, IV PPI continuous infusion for 72 hours. C, IV PPI BID for 72 hours. D, PO PPI BID for 72 hours. And the answer is C, IV PPI BID for 72 hours. A recent meta-analysis concluded that the risk of rebleeding in patients with high-risk ulcers, i.e. bleeding, non-bleeding visible vessel, or adherent clot, that were successfully treated endoscopically was comparable for patients placed on intermittent PPI versus continuous PPI infusion. So to save costs, you can place them on PPI BID IV. 3. A 42-year-old female with alcoholic cirrhosis and history of esophageal variceal bleeding presents with hematemesis and hypotension. Which of the following should occur even before EGD? A, transfuse for goal hemoglobin greater than 10 gram per deciliter. B, IV PPI bolus and infusion. C, IV octreotide bolus and infusion. D, IV meropenem. And the answer is C, IV octreotide bolus and infusion. Although IV octreotide has not been proven to decrease mortality in variceal bleeding, it does reduce rebleeding. Prophylactic antibiotics have been shown to reduce mortality in variceal bleeding, but include specifically quinolones or ceftriaxone in areas with high resistance to quinolones and potentially advanced cirrhotics. Transfusion goal in variceal bleeding is modest, with goal hemoglobin approximately 8 grams per deciliter. It certainly is not unreasonable to consider placing them on an IV PPI drip as well, as these patients could certainly have a non-variceal source of bleeding, but in this particular patient, the best answer would be IV octreotide bolus.